then we have to have a healthy cardiovascular system and we have to have healthy heart muscle. Because if it is not healthy, we have decreased what? Cardiac output. And then everything else sucks. So you can see the vasculature there. And you see how those vessels get much smaller when it gets to our fingers, our toes, and to each organ, right? And so if I have decreased cardiac output, I'm not perfusing to all of those things. So you can see how the heart obviously is in the middle of this system, and then you can see how your head is a short distance. So whenever our body is in a shocked state or a low cardiac output state, we shunt, right? So we shunt blood to this big vessel area, and everything else peripherally, whether it's arms, legs, or organ systems, then get decreased perfusion. What does blood carry? Oxygen. Do we need oxygen to our organs? Absolutely. So whenever this starts happening, this is how we can see things in our clients. So one of the first things you can see is decreased urine output, right? I'm not perfusing to my kidneys well. What is the most important pulses I told you to check? On your client when you're doing your assessment. No, that's for this. Your feet. Your feet. Just look at your feet. So your feet are the most distal part of your body. So if I start seeing decreased cardiac output on my client, I can start seeing that in my feet first, right? So I have increased cardiac or capillary refill time. Maybe they're cooler to the touch. All those things, right? It's the most distal part from your core. So you can see why this is very important. Doing a closer look, we know that the heart works by receiving oxygen and nutrients from the blood. We just talked about that. And then we know that, I don't know if you know, you need to know. So the heart is a muscle, right? And we know blood pumps through it, but the blood to it is the coronary arteries, right? Does everyone get that? And you think that's simple, but I worked with cardiac nurses that did not understand the difference. Did you not? So blood flow through the heart, you know, the pathway through the heart, that's one separate thing. And then blood flow to the heart. That's the coronary arteries. You have to feed the heart muscle, blood, in order for it to work. So, and then we know the electrical system. Y'all remember it? SA no, AB no, bundle of pins, left and right, Purkinje fibers, ventricular, right? Yes, got it. So we have these two systems that have to work together in order for the heart to work. And then whenever that electrical conduction goes through to the Purkinje fibers, it goes to the ventricular muscle and it contracts and we squeeze blood out. And then you can see right here in that aorta, that's where you have the coronary sinuses. What is sinus in medical terminology? What does it mean? It's an opening of some sort, right? So there's an opening in the aorta for these coronary arteries to receive blood. You good? A and P. Alright, so together these systems work, and it has to work very well. So we talked about EKG. If we have a dysrhythmia, it causes the heart to not pump regularly or pump too fast, all those things. So that decreases what? Cardiac output. Alright, so cardiac output is the volume of blood pumped by the heart each minute. So again, if the heart's not pumping correctly, we have decreased cardiac output. It should make sense. Understand it, absorb it. So normal cardiac output, you can measure this, obviously. So remember I talked about there's all sorts of invasive lines and we can monitor just about anything. So normal cardiac output for an adult is 4 to 8 liters a minute. However, this is not constant. So I'm probably pumping a lot more right now because I'm walking around and I'm anxious. Okay? Got the little panics. So I'm walking around, whereas y'all's is probably a bit more stable. So when a client is laying in bed versus when we sit them up on the side of the bed, if they are being monitored with this, I'm going to see a fluctuation in this, just like heart rate, just like blood pressure. So it's calculated by the heart rate times stroke volume. Do not put too much stock into this. I'm not going to have you calculating that. There will be calculations later, but it ain't that, okay? Alright, so then there's cardiac index. So this is cardiac output related to body surface area. So it is cardiac output divided by body surface area. This is pretty much just a more definitive number. It is a more specific number, okay? So 4 to 8 is kind of very generic, where cardiac index is a lot more. So if you ever go into CVICU, they can be hooked up to a Swan, and a Swan is a type of measuring device, and there's all sorts of leads that come out of it. And you'll see a monitor that says CO/CI, and it's just the cardiac output and the cardiac index. And those nurses look at those numbers. That's about as much as you need to know, okay? And then we know that heart rate is simply the number of beats you have in a minute. So we should know normal, Brady, and tachy by now, right? Okay. Stroke volume, amount of blood pumped by the left ventricle, each contraction. So we know that your blood, or your heart pumps blood, but that left ventricle is a larger ventricle, and so it is more responsible for pumping blood to the body because of the pathway of the blood through the heart. And so this stroke volume, which is the amount of blood pumped by the left ventricle each time it contracts, is influenced by 3 things. Okay? Preload, afterload, and contractility. So when you hear the word preload, automatically just think volume. Preload volume, preload volume, preload volume, always. And when you hear the word afterload, think pressure. So preload is volume, afterload is pressure. So before we move on there are medications called afterload reducing agents. What do you think that is? It's blood pressure medicine. How stupid is that? Why can't they call it one thing? I don't know. But when you start understanding preload is volume, afterload is pressure, there are medications that decrease preload, diuretics. Okay? And then contractility is simply just the force that your heart beats at. So what, if I have low contractility, what kind of medication might the client be put on? Positive what? Inotrope. Positive inotrope increases contractility. Okay? So you can see how the medications that are ordered for these certain things, directly how it responds to the body, right? All right, so here's the hemodynamic monitoring. So anytime we're monitoring someone, it is introduced by a catheter of some sort. So if we are putting an IV in a patient, that is a catheter. If we're putting any sort of monitoring devices like the Swan, it is put in through a catheter, okay? And then there's leads all connected to it at different places. So hemodynamic status, we can assess several things. We can assess the central venous pressure, pulmonary artery pressure, pulmonary artery wedge pressure, cardiac output, and art lines. That's a lot. These two right here are right out of the NCLEX book, so that's only two that you actually need to focus on really for life unless you go into like CVICU. So normal CVP is 2 to 6. And when I'm looking at that central venous pressure, if it is increased, that shows that my patient has more intravascular volumes. Okay? So they are intravascularly, they have way too much. And then if it's decreased, the opposite, they're hypovolemic. So you can see where this monitoring this number is really important. A lot of times right after heart surgery, they can put up to like 15 pounds of fluids on the patient. So we'll have really high CVPs of like 15, 16, and it lets us know that we have a lot of fluids still on board. Okay. And then pulmonary artery wedge pressure, it's really the same. So if we have an increase in the number, it's hypovolemia. If we have a decrease in number, it's hypovolemia. Makes sense, okay? And then you have your intra-arterial line pressure. That is separately important. So in a critical care patient, especially when they are being put on any type of vasopressors that we talked about in critical care beds, they need an art line. That is a better way for us to assess their blood pressure on how we titrate these medications than a blood pressure cuff. Okay? So an art line is simply exactly what it sounds like. They put a line into an artery and you can measure it because your artery contains pressure, right? Veins do not. We do not place these. Sometimes if you work in the OR maybe, but At Baptist, it'll be like the CRNAs or anesthesia. Where I work, the respiratory therapists put them in. And it can be anywhere you have a major artery. So they'll usually use femoral, radial, every now and again brachial. And this is also, whenever you're looking at a monitor, it will be a red wavelength. So if you see your patient has a red wavelength when you go to critical care, you'll know that they have an art line in place. Any questions about that? I don't know, we honestly didn't use pulmonary artery wave pressure because it's contained in a swan and we didn't use a lot of swans. The CVP, it'll be like a teal blue, but that's not. Okay. Alright, coronary artery disease. So this is going to be a big one that we'll cover. So coronary artery disease is when the coronary arteries become obstructed with atherosclerosis. What is atherosclerosis? Life, right? Cholesterol, fat, all those things that everyone in Arkansas is going to end up with because we eat real good. It's job security. It cracked me up because at the hospital I worked at in the cafeteria, not for patients, but for family and staff, Thursday was fried chicken day. I was like, job security. And it was freaking good. Okay, so the coronary arteries become obstructed with this plaque. So remember how we talked about the coronary arteries are what feed the heart muscle blood. What gives the heart muscle oxygen, nutrients, all of that. So if I have, so this plaque, when you're looking at the coronary artery, it's not just in the artery, it's still in the wall of the artery. So there's still a layer of tissue over it. Does that make sense? So it's in the wall of the artery, it's not just within it. So this plaque builds up, and you can see, and I've got a little model up here. During the break, y'all can play with it. So normal cross-section of a coronary artery, right? And then we have different degrees of blockages, okay? So when the coronary artery gets blocked, what cannot get through? Blood, which carries oxygen. So what happens is, if I have a wide open lumen and I start filling it with plaque, it's not completely occluded automatically, right? This takes time to develop. It takes time. This is why most people that have this are elderly or middle age. It's not typically like people in here. But the inside of this lumen gets more narrowed, okay? And that can be fine up until a point. So over time, this atherosclerosis, or I'm just going to call it plaque from here on out, okay, because I can't say it right. Plaque, it starts to build up. So then, I'm fine in my day-to-day, but then this is what happens. You got Peepaw, who is fine in his day-to-day, sits in his recliner. His daily routine is to get up, walk his little puppy, casually down the street. He sits in his recliner, and his activity really is from his recliner to the bathroom, recliner to the kitchen. That's his life, right? Little circle. Well, then hunting season comes along, and he's like, I'm going to deer camp. So Peepaw walks to his deer stand, and he's like, dang, start feeling a little something. Gets to his deer stand, he sits down, and he's okay. Then he shoots a deer. What happens whenever that happens? Adrenaline, heart rate, blood pressure. Now, this area that is narrowed, it can't keep up the demand. So it's really, really, really small. So blood flow has a really hard time getting through. So that heart muscle past it is not getting blood flow. Okay? That's angina. That's chest pain. Okay? So then, we talked about if there's a little layer of skin within that vessel, it's over that plaque, right? It's within the lumen. When that ruptures, what does your body do when something gets cut? Puts a clot on it, right? So if I have an extremely narrowed vessel and that little layer of arterial wall ruptures and I develop a blood clot, now what happens? Completely occluded. That's a heart attack. That's a myocardial infarction. So ischemia causes angina, causes that chest pain. But then total occlusion causes an infarction, which is tissue death. We cannot bring anything dead back to life, right? So that's why it's really important when they start having the chest pain to be seen. That's also why it's really important to know that we always rule out cardiac first, right? Because we've talked about before, how many things can cause chest pain? So many things, okay? Does it make sense? All right.
So,
Go ahead. Yeah.
so what ruptures it? What ruptures that little lining is that
You
pressure?
just overstretch it. It's just too much. That plaque gets too big, and then there's too much stress, and it just ruptures. Yeah. It's just kind of. It's also like edema, right? If I have a crush injury on my leg, it can swell up to a certain point, and then what happens? It's just within that. So then we have to cut it open to get it released. Same thing. It can only do so much. All right. So risk factors. So who is at risk for developing coronary artery disease? So we have them categorized into modifiable and non-modifiable. What is the difference there? Yeah, one I'm in control of, and the other one we just got dealt. Thank you, parents. Yeah, and grandparents, and so on and so forth. Okay. So modifiable ones are things that we're in control of. So tobacco use, hyperlipidemia, and high cholesterol. That usually comes from diet, right? Hypertension, diabetes, obesity, and sedentary lifestyle. Those are modifiable risk factors. And then non-modifiable, gender, I'm sorry guys, you're at higher risk. Race, white dudes, sorry. And then older than 45. So you can see where it's kind of in that age. And then genetics and family history play a huge part. The youngest coronary artery bypass surgery patient I ever had was 33. And he was not obese. He was a white male, but he was a truck driver. So his diet. He also had some genetic things, but and I'll tell you a story about him later. Okay. All right, so we just talked about this, but it cannot be enforced enough because this concept can be kind of hard to grasp. All right, so angina versus MI. So this is another picture of the coronary artery. This is fully open, and then see this layer of tissue still, so you can see that plaque is within the vessel wall. So when blood flow to the heart is compromised, this is what causes chest pain, right? Because it's kind of like putting a rubber band on your finger. It doesn't hurt at first, right? And then after a few seconds, it starts turning purple, kind of starts hurting, right? And then what happens if I don't ever take that rubber band off? My finger's gonna fall off, right? So chest pain or angina that is unrelieved by rest or nitro and lasts more than 15 minutes is the difference between stable angina and unstable. So what that means is if I'm having chest pain and I sit down, and it goes away, that's stable angina, okay? But if I'm sleeping in bed, I'm chilling, it's the middle of the night, ain't nothing waking me up, and all of a sudden I wake up from sleep with massive chest pain, that is unstable angina. It is not predisposed by any sort of activity, okay? It just happens. And then we know that if someone has angina and they have nitro, little nitro tablets, for one, that should tell you they have a history. Otherwise, they would not have the prescription, okay? So know that they have a history. That they can take, what's the prescription order for that? 1 every 5 minutes times 3 sublingual, right? All right. And so when the plaque within the coronary artery ruptures, this is when those platelets make a clot. And then this creates a blood clot that completely blocks that coronary, which then completely blocks the blood flow. So this is why when you're in the hospital and med-surg, how many times have y'all given an 81 milligram aspirin in the morning? Like everyone. It's the little yellow tablet with the heart. It's the one they like to drop under the bed. Every time. So evidence-based practice shows that if we give people an 81 milligram aspirin daily, so aspirin works by what? It's a platelet aggregate. So it keeps platelets slick. So if we take this every day, it can kind of keep this from completely occluding. So that little low-dose aspirin, isn't that cool? So then, when they come into the ED though, we give them a full strength dose, which is four low-dose chewable. We have them chew, so it's 325. We have them chew them up, because we want to get it in there really quick. But if this is not opened back up, it can lead to a complete MI, and then that can lead to sudden cardiac death. Depends on where that MI is, which coronary artery is blocked, because past that coronary artery is where the muscle does not get blood flow, so that muscle dies. And if that's an area of muscle that contains a big electrophysiology part, my heart's just going to quit working. Yes?
Are we treating stable injury? Is there a treatment they need to get, or we're just monitoring?
No, you just need to know that it goes away with rest. Yeah. And I will hit on that. You never ignore chest pain, but we'll talk about it in a second. Okay, so again, angina, chest pain classified as stable or unstable. Stable occurs with physical activity and is relieved by rest or the sublingual tablet. And then unstable occurs with physical activity if it is intractable. So if it does not go away with any sort of intervention, okay? And then at rest. And severity and duration over time are going to increase. So any chest pain is a medical emergency, but especially unstable. The reason I say that is because if they have stable angina and they have nitro, they have a history. It's still a concern, but we can kind of expect it, right? And there's a treatment plan in place. But all chest pain should be taken seriously. And then early recognition is essential, because what happens if I don't get blood flow back to that cardiac muscle? Cuts, and we can't bring anything dead back to life. So that heart muscle is deprived of oxygen. And we go, what it says right here is essential to save cardiac muscle door to balloon time. So that just means how fast we can get them to the cath lab, which needs to be real quick, real quick. So the quicker we get people in and assess, and we figure out what's going on, we can get them to the cath lab and open that back up. Because if that heart muscle is deprived of oxygen too long, even if we get oxygen and blood flow back to it, is it ever going to be the same? No. It's not going to perform as well. So then I'm going to have ventricular dysfunction, and we'll talk about that in a second. All right, so angina clinical manifestation. So what does it look like? So it presents as tight, squeezing, heavy pressure, constricting feeling in the chest, substernal. It's telltale signs. People walk in, clutching their chest, easy to identify typically. And then a lot of times they'll say that the pain is radiating to their jaw or their arm. I will say though, I have spontaneous pneumos, and this is exactly how it feels. So I've just had 4 of them, but it feels exactly the same. So, but always get checked out, because it could be that too. All right, so what do we do for it? How do we manage it? We just talked about it. Yep, nitro, vasodilator. So then, if you did not get that concept in the first one, here's you another picture. So vasodilation, I didn't bring a syringe today, I'm sorry. Alright, so nitro we know vasodilates, and it vasodilates everything. But it works on arteries and veins, but we needed to open up those coronary arteries so that we can get blood flow back. We just talked about that, but client has a history, they may be prescribed little sublingual tablets. And then if they have chronic angina, so if they have angina every single day, because of their coronary artery disease, they may be prescribed a long-acting nitro. So like isosorbide, mononitrate, those are the ones they take, and it works over a certain period of time all day long. Okay? So that's important for us to know that our clients are taking that. So then if rest and nitro does not relieve it, it is unstable, and then it is a medical emergency. But again, we always rule out cardiac first, right? Alright, so we talked about coronary artery disease. So coronary artery disease is just the disease within the vessel, right? It develops over time, increases over time, and we want to address it before it leads to an MI. Okay, so now we're into the MI itself. So it's a myocardial infarction. We know infarction means death. So this is whenever this blockage in the coronary artery, that blood flow is compromised for so long that the ventricular muscle then dies. Okay? And this is really hard to tell that it happens. So if they wait too long to come in, especially because you just saw that it is males that are more likely to have this, really hard to get them to come to the doctor a lot of times. And that's just statistical. So you're like, no, it'll be fine, it's just indigestion, him all around. Well, the longer you wait, the less blood flow we're getting to that muscle. So in that case, even when we get them to the cath lab, we open it back up, they might be okay for a day or two, but dead tissue then sloughs away and we have a massive hole in our ventricle and they're gonna last 30 seconds. Okay, so let's see, myocardial ischemia. Ischemia leads to tissue necrosis, so that's what happens. And then we know that ischemia is reversible, so it's just like the rubber band on my finger, right? It's turning purple, it starts to hurt, but then if I take it off, what's gonna happen? Blood flow gets back to it, it turns to normal color. If I don't, then it's going to end up being more and more compromised of blood and oxygen, and then it's going to die. So ischemia, we can reverse. Infarction, we cannot. Y'all understand that? Alright, so then what does that look like? Well, it's going to start with angina, because we have to start somewhere. So it's going to start with angina. A lot of times people come in with chest pain, nausea, vomiting, and they're diaphoretic. Those things kind of go hand in hand, okay? If you're having chest pain, is that going to make you anxious? Yeah, and if we have a low cardiac output, how does our body compensate for that? What's it do to your heart rate? Raises it. Anytime you have an elevation in heart rate, you're going to have that flat or flat because of the central nervous system response, and it's going to make you anxious, okay? So anxiety, palpitations, and tachycardia, you're going to be short of breath. So when you're running around and your heart rate's high, are you short of breath? Yeah, so your heart's running a marathon and you're just sitting still, but you're very short of breath. And then with decreased cardiac output, I have syncope, I have decreased level of consciousness, of course dizzy, weak, confused, pale, cold, clammy skin. All of that is because of decreased what? Cardiac output. That's it. So of course we know that these signs and symptoms vary from person to person, and women have the most random signs, of course, can't be typical. Sometimes they're like, you know what, I've been tired for 3 days, I'm a little nauseous. Well, that's every day. Women are, that's every day, okay? I'm tired and I'm nauseous. So women can have very uncharacteristic signs. And so if it is a feeling or something that is out of their daily norm, then you always want to rule out cardiac. So always rule out cardiac first. There's probably going to be some prioritization situations. Always rule out cardiac first. Okay. Yes.
Sorry.
No, you're great.
So, I know when we talked about the EKG search, you said that if it's a STEMI, then it will show that ST elevation.
Uh-huh.
So if it doesn't go all the way to an infarction, is it gonna show up at all this blockage on an EKG search?
So you can have a STEMI or a non-STEMI.
Okay.
So I don't make it
So
a
really,
me.
so EKG's not really done.
So where that comes in, and we'll talk about it in a second, but where a STEMI comes into play with a 12 lead is it can tell us where they're having an MI. It can tell us what coronary artery is blocked and what part of the heart muscle is compromised. If they're having chest pain and their troponin is elevated, but they have no ST elevation, we're still going to do the same thing. It's just that it gives us more information.
So okay, so like with coronary artery disease so long.
It's not
we
gonna
have
show you.
to do like an angiogram. or something.
We'll talk about some diagnostic
Okay.
tests in a second. Yes. Good question. Okay. Yeah, okay. So labs and diagnostic tests. So remember how I talked about how almost every patient gets admitted through the ED, right? So when they walk into the doors, do we have all the information we need? No. How do we make a diagnosis? Assessments and Labs and diagnostic tests. So diagnostic tests lead to a diagnosis, okay? So we have some blood tests. So we have a cardiac enzymes, and then your top cardiac enzyme is going to be a troponin. Do I have lab values on there? No. If I ever ask a question with these three labs, I will give you the range and just know if it's elevated, it's bad. Okay? If it's high, it's bad for all three of them. Because there are two different troponins. There's a troponin I and a troponin T, and it really just depends on which one your facility uses. Regardless, we do not want an elevated level. So cardiac enzymes are produced when cardiac muscle suffers an injury. Okay? When your cardiac muscle suffers an injury, then these cardiac enzymes are in the bloodstream. It does not always have to be an MI. What if I have a car wreck and I hit the steering wheel real hard with my chest? You think I might have a bruise on my heart? Would I expect a troponin to be elevated? Yes. Cardiac injury, right? If someone comes in AFib with RDR and we shock them out into normal sinus rhythm, you think I'm going to have an elevated troponin? Yeah, just shock them, you know? So it's any injury to the heart muscle, okay? But we're looking at it from an MI standpoint, but kind of keep those other things in your mind. So you have your troponin, your CK, and your CKMB. So troponin, any positive value indicates damage to the cardiac tissue. So this is the gold standard. This is one that we really, really like. But whenever you have a client that comes in with chest pain to the ED, a physician's going to order probably cardiac enzymes, and it's going to be those three together. Troponin, CK, CKMB. CK shows cellular injury, but it is not exclusive to cardiac. So any cellular injury is where that so you can see how it's helpful, but it's not specific to cardiac. And then CKMB is more specific to the cardiac muscle. Okay, but troponin is the gold standard. You're all hearing me? Alright. And then we know that, very important, we have our EKG. So we know that this records electrical activity of the heart. And anytime we are suspecting an MI, we need a 12 lead. Because a 12 lead does not show us, we're not looking at it for rhythm. I can just get a strip for rhythm. This shows heart oxygenation. 12 lead shows heart oxygenation because it can show us where the heart is compromised of oxygenation. Because we know that a coronary artery block is not getting blood flow to that muscle. What does blood carry? Oxygen. So this is what it shows you. Yes, ma'am.
So if you have like, they're building and you can see that they have a, second degree block, that's the same for that second degree block on
So
the
that's a rhythm.
EKG. So that doesn't have anything to do with the actual
No,
oxygen.
that's an electrophysiology problem. Yeah. So that's
How do you
EP.
know if it shows block?
I'll show you in a second, but that's electrophysiology, and we're talking about the plumbing. So that's your electrician, and we're talking about the plumbing, okay? Two completely different cardiologists as well, by the way. Y'all know that? So we're talking about the plumbing issues, but I will show you how you can see those areas of lack of oxygen. But yeah, two separate problems. All right. So when you're looking at your 12 lead or even a strip, say you had a strip first and then they complain of worsening chest pain. The T wave can be inverted, so it's going to be upside down. So we can see this is the T wave here, so it's going to be upside down. ST segment we know is going to be elevated, and if it's not, then it's a non-STEMI. So ST is ST elevation MI, remember? And then non-STEMI just means that it's non-ST elevation MI. They're both MIs. It's just one gives us more information. The other one, but they're both MIs and they're treated the same. And then remember how I talked about how a P wave is not necessarily present on everyone, but if they've had an MI in the past, or if they're like having an MI, you can have a P wave. So PQ is going to be that negative deflection. And that's just kind of like scar tissue. So electrical impulse has a little bit harder time getting through. Alright, so we're going to look at it. So let's go back for a second. You know that a 12 lead, y'all ever all seen a 12 lead? How it looks like this? You know, it's a full-size piece of paper and it's just got a lot of rhythms on it. And you're like, I don't know what that is, but they told me to put it in chart 223, so there it is. How many of y'all done the 12 lead? Lots of stickers, all that stuff. Okay, so that's what a 12 lead looks like. And so so this is that 12 lead, okay? The one on the previous screen, this is another one. So you can see where it says lateral, inferior, septum anterior, lateral. This is what I'm talking about. So if I have ST elevation in these 3 leads, then it shows me that I'm having a MI in the inferior part of my heart. So remember how y'all labeled the coronary arteries for your lecture prep? So this means I have a blockage in my right coronary artery. Okay? Inferior part of my heart. So it is not important for you to know these details right now. I will not test you on that. But that's how they can tell. Like, oh, they're having an MI more than likely in this right coronary. Okay? And then lateral points really to that left ventricle. So that's real bad. So if I get a 12 lead and I have an ST elevation in those, I know that I'm having a big, big problem. So that's what they look at it for. You're looking at all these strips, but it can tell you exactly what part of the muscle is being compromised, which gives them more information for that heart cath, right? So then you can see up here, this is a normal EKG, PQRST, this is normal. And even if you don't know all the details, I can tell that this does not look like this, right? It does not look the same. So this is your ST elevation. And this is ST elevation. So it'll come straight off that R. It's very clearly, you can be like, that looks bad. Alright. So that's our labs and diagnostic tests, and then we're going to continue on to our diagnostic tests. So now we have the heart cath, or cardiac catheterization. So this is where they're going to go to the cath lab, which is it's usually in the area where the OR is. And there's actually specific nurses that are hired for cath lab. I do not recommend starting out of the gate in the cath lab. Very fast-paced, very intimidating, a lot going on. But this is where they insert a catheter into an artery. It's typically femoral, or if your cardiologist is real good, it'll be radial. So they thread a wire up through all the way to the heart, and they inject dye. And when they inject this dye, it's under fluoroscopy. So all that means is they're taking x-rays so fast that on the screen it looks like a moving, like TV screen. So they can watch that dye go through. So when they watch that dye go through the heart, wherever it stops in the coronary artery, they know that there's a blockage there, right? So when you're looking, right here, you can see that there's a blockage. See it? See how it's way more narrow? So this is your LED. You can see where it is super narrow right here. You can also see how this is kind of ballooned out a little bit, where the body's compensating. So this doesn't happen, this type of blockage does not happen overnight, right? It takes some time. So your body is fantastically and wonderfully made, so your body compensates, and so it'll kind of blow out that coronary artery, trying to repair it itself. So then when they see this blockage, they can identify exactly where it is, and then they can fix it at that time. Understand that fluoroscopy involves contrast. Is that important for us to know? Yes. Why? Allergies. So many people are allergic to contrast dye. Does that mean we're not going to do the heart cath? No, we're just going to give them some Benadryl and some steroids and get them onto that lab. I will say though, whenever you're looking for reactions, a lot of times it can be very latent. I have seen them. It could be 24 hours later, you're fixing to send them home and they turn red as a tomato, and you're like, shoot, something. Because not everyone knows they're allergic to contrast dye if they've never had it before. So that's why we ask them, what other things do we ask them they're allergic to?
Shellfish.
Shellfish. Yeah. So sometimes it can be easy, sometimes it's not. And then metformin, that's a big one. So what's one of the biggest risk factors for coronary artery disease? Diabetes. So they are on the metformin, okay? So we want to hold that or we'll shut their kidneys down. Also, contrast dye is very nephrotoxic. It's also very hard on your kidneys, right? So what do I need to assess before I send my patient to the cath lab? Creatinine. We need some labs. If the creatinine is high, am I going to not send them to the cath lab? No, we're going to send them, but I'm going to keep doing some fluids when they get done. ABCs, right? This is a C. This is priority. I can deal with that potassium later. Okay, so then the cardiac catheterization or the heart cath, what is my role? What is my role as a nurse? Why is this important to me? I'm not doing the heart cath. Why do I need to know? Well, it's important because whether you're the nurse on the front end before they go or whether you're the nurse afterwards, there are a lot of things we need to do. So we need to make sure that consent is verified because it is an invasive procedure. So anytime we have an invasive procedure, they have to have consent. Verify MPO status, like moderate sedation, right? They're going to be put under moderate sedation for this. We're going to give them a little propofol or midazolam and fentanyl. Yes.
Do we answer the questions about the consent, or do we call the doctor?
Listen, whatever they teach you in your book, do that. And then whenever you get to work, and you'll figure it out. But whatever you're taught, go by NCLEX World. And then later we'll talk about it when you're a nurse. Okay. And then, so verify MPO status is very important. But if they come in, the ED, and they're having an active MI, we're still going to send them to the cath lab. Okay? We'll just give them some Raylan or something to keep that down. But for scheduled caths, you need to have them MPO every night. Prep, shave, and clean. So this is important because where did I say one of the access points are? Femoral. Is that clean? No. So we need to shave, and then every hospital will have different types of wipes, but it's like a CHG wipe. You're going to wipe that area down. And then you're going to verify allergies to contrast dye, shellfish, and iodine, and you're going to make sure that armband is on them. Regardless if they have allergies or not, they need to have an armband that says no drug allergies, or it needs to verify that they have allergies. Because if there's not one on there, what does it look like we didn't do? It says it. Like I have one. And then assess renal function. Why is that important again? Contrast is nephrotoxic. So again, if their creatinine is high, what is my role in that? I can't order fluids. I can give them what they order, but what's my role? I'm all communicating. Hey, just letting you know their creatinine is 2.5. Okay, any questions on nursing role before? Alright, nursing role afterwards. So we need to know what happens in the cath lab. They go to the cath lab and they're going to be put under moderate sedation. They're going to have something put into an artery, whether it's femoral or radial, and they're going to be given contrast dye. Okay? And then if they decide to treat that MI or that blockage, they'll get a stent. So we'll talk about, yes?
Sorry. Are we communicating the creatinine to current ER provider or to the cath?
Healthcare provider. We don't differentiate, it's all healthcare providers, okay? I would never treat you like that. Okay, so we know what happens in the cath lab now, right? So after I get them, it should be pretty easy to understand what I need to monitor. I need to continuously monitor them for so many times because they've had moderate sedation. So this is a standard. Every 15 minutes times 4, every 30 minutes times 2, and every hour times 4. And then it can just be every 4 hours. That's a very standard order. And y'all may be way better of a nurse than I am, but I had to write all those times down on my sheet and cross them off as I did it. Because you're busy. But you have to make sure you assess that. So important. Because they've had moderate sedation. And then we're gonna monitor that site, access site, for bleeding or hematoma. So if they had a heart cath and they did not stent them, sometimes they'll go ahead and take the sheath out of the groin. If they did stent them, that sheath is gonna be in the groin. What is this sheath? Do y'all know? It's just like an IV catheter, but it's huge, and it's in the artery. Kind of important, right? So they'll have, if they did get an intervention, they'll have this sheath in for however long the physician wants it to be in, okay? It's in at different times. And then if they've had radial access, they'll have a band called a TR band, transradial, and it has a balloon on it and it holds pressure, okay? So nice, because they can get up and pee, they can go to the bathroom, whatever, so nice. When they have femoral access, what do I need to do? Bed rest, right? I need to monitor the site for bleeding. When we do take that sheath out, it's just a booger holding pressure for a femoral artery until it occludes. So you can see where that kind of care can change depending on just access point. And then I'm going to give them fluids, so they'll always go down with fluids. You start 2 large IVs if someone's having an MI, and you're going to have some fluids going. So I'm going to continue the fluids when they get back, but if they have, because they've had that contrast, whether they have renal issues or not, you want to get that contrast out of their system. But if they have renal issues, they may be prescribed more fluids, okay? The importance with that is, however, they've just had an MI, so what are they at risk for after they've had a big event to their heart? Cardiogenic shock, right? And we'll talk about that specifically after a while. But if I had a big event to my heart, I can go into cardiogenic shock. So I need to really monitor them, especially giving them all these fluids. They may not be able to handle it. And then maintain bed rest for femoral access and keep the extremity straight. No sitting up. This sounds real easy, but what did they get during the procedure to put them to sleep? Moderate sedation. Everyone handles it differently. I mean, people are so dramatic when you tell them to lay flat. I mean, I know it's not comfortable, but Lord, they're like, I'd rather die. And I'm like, well, you about to. You need to lay straight. Because when that sheath is still in it, even though it's a straw, and I have some, and I freaking forgot all this, but they're about this long, and it's a straw. So if they sit up, it can really perforate. Like, it's important to sit down. And I will say, instead of leaving them flat, your bed can be straight, and you can reverse Trendelenburg them a little bit. That helps a ton, okay? Just pick their head up, put their, so you need to have them flat, and then you need to have that leg straight. They're confused, they're coming out of moderate sedation, you'll go in there and they're frogged in their bed, and you're like, oh Lord, straighten this leg back out. And they're like, oh, and you just told them 7 times, and they just don't remember. So you can see where that nursing intervention afterwards can be very involved. So we've had labs, we've had diagnostic tests. So other diagnostic tests related to coronary artery disease, we have an echo. So an echocardiogram is just an ultrasound of the heart. It is non-invasive, right? It's just a picture that I get over the heart, not me, but Echotech. This cannot tell us if they're having an MI, cannot tell us anything about the actual MI. It's not like they're having chest pain and I'm ordering an echo. I'm going to order an echo afterwards so that I can see where the heart muscle is not working very well, right? So it can show that weakened area of muscle. So it's more going to be post-MI. And then it can also give us the ejection fraction of the heart. So left ventricular ejection fraction is a huge number and a huge help after they've had an MI, especially if they've had a lateral MI and that LAD was affected, because that's the whole left ventricle. So I can get a left ventricular ejection fraction number, and it can tell me how well that left ventricle is actually pumping. So what's the expected normal range? What does it say? 55 to 70, okay? So you get a patient comes back and they're like, the doctor said my EF is 65, because they think it's out of what?
100.
100. physicians love communication, let me tell you. So you're like, that is perfect, and like, you're lying to me. So you need to know that a normal EF is 55 to 70. Very rarely do you see 70, but an EF of 65 is great. EF of 55 is great. Okay? You need to understand that, especially for education purposes. And then the stress test. So this is a test that's done for those higher risk clients. So what that means is we know what's involved with a heart cath. We just talked about it. Moderate sedation, contrast dye, right? Accessing an artery. So if I have someone that's really high risk, say they need to be on blood thinners every day, and it's not safe for me to stop them in order for them to have a heart cath, then they're a high risk patient. A chronic renal failure patient, not ideal to do a heart cath on. Patient with chronic COPD or any sort of lung thing, not a great candidate to put under moderate sedation. Does that make sense? You're kind of getting a clinical picture. So clients that are very high risk, I'm not going to send them, and this is not an acute episode. This is something where they're having stable angina and they're letting their cardiologist know in the office. This is not happening in the emergency department, okay? So high-risk patient, they're experiencing, they're experiencing stable angina, so we're going to check it out, but we're not going to take them straight to the cath lab because that's higher risk. More risk than what this patient needs. So we're going to assess their tolerance of activity. Because what did we talk about happens when we have coronary artery disease that has progressed? What happens whenever they have more activity? This is when they have chest pain, right? Because my day-to-day, I'm walking from my recliner to the couch, but I can no longer go check my mail. That's a big one. They're like, I can't walk to my mailbox and back without chest pain. So they do this stress test where they walk on a treadmill, they're hooked up to everything, and they assess their 1280 kg the whole time they're doing activity. So then they can see if there is issues there. And I used to do these, and you have to check their blood pressure constantly too. You ever check someone's blood pressure as walking on a treadmill? It's really difficult. And then if they are not physically able to walk on a treadmill, they'll do a cardiolite stress test, which is where your nuclear medicine techs come in. NucMed, they're like geniuses. So that they'll inject a nuclear medicine agent that will cause the same effect, but they won't have to do the activity, okay? So it'll give you an indication. The issue with this is if it's positive, what are we gonna do? We're gonna take them to the cath lab. But if it's negative, then they're gonna decide what the best treatment plan is. Does that make sense? Any questions on the stress test? All right. So then how do we manage coronary artery disease? So we have medical management, which is going to be medications. We have interventional management, and we have surgical management. 3 more minutes and we'll do a break. You started over your time. Okay. All right, so medical management. So these are going to be the medications. Goals for the medications are, we've got some different goals here. We're going to stop the formation of the blood clot because that's what completely occludes the coronary artery, right? And then we're going to control those contributing factors that puts people at risk for coronary artery. So it's going to be kind of a twofold here. And then, of course, other parts of medical management are diet and exercise. People kind of tend to look over those, like, give me a pill. All right, do not memorize this list. Okay? Don't freak out, don't panic. Just know that if someone has coronary artery disease, they're going to be on something for their cholesterol. They're going to be on some sort of blood clot preventing agent. And then you have some other medications here. So metoprolol to decrease the workload of the heart. Nitroglycerin is a vasodilator. So this is something that someone living with coronary artery disease, because a disease is something that they live with, will take on a regular basis. All right, any questions about medical management? Okay. Interventional management. So we already talked about the cardiac catheterization, but that is a diagnostic test. The cardiac catheterization is just a diagnostic test. That's what the patient goes to diagnose whether they have coronary artery blockage, okay? Now, while they're in there, if they see the blockage, then they can do an intervention. Well, we good? So there's two different things. There's a coronary angioplasty and there's the coronary stent. So angioplasty is a balloon and a stent is an actual stent. So I've got some pictures here. And this is all called percutaneous coronary intervention, or PCI. I know, all the time. So they'll say, oh, they've got, when you're consenting them, cardiac catheterization with percutaneous coronary intervention and all indicated procedures. All this stuff. Alright, so coronary angioplasty is the balloon. So I talked about that catheter being put up there, right? So at the end of the catheter, there will be this balloon. You can see where there's a blockage in this first picture. Then they open up the balloon and it pushes all that plaque to the side. Okay, it just opens it up. And then the coronary stent is the same. It has a balloon on it, but whenever they open it up with the balloon, a stent stays in place, right? It's just like, don't go anywhere. I got you. Okay? You're like, where would one be benefited versus the other? Why would they not do a stent? Well, if someone has a stent, that is a foreign object, and what does your body want to do to that? Huh? Kind of. What else? What's it build on it? Blood clots. Right? So then if I have blood clots that put on it, what's it gonna do? Occlude. Right? So then what does my patient have to be on? Blood thinners. And aspirin is not gonna work for this. So these are clopidogrel. Y'all heard of Plavix? So they're gonna have to be on Plavix. There's Brilinta. Y'all have all seen the commercials. So they have to be on this type of blood thinner. The issue with those is that there's not a reversal. Now typically they take it every day, so that means the half-life is usually worn out very quickly. But if someone has a high risk of falls, are they a candidate for a really strong blood thinner every day? No. Or recurrent GI bleeds every day? Those types of things. So then that determines the treatment plan. Does that make sense? So if my patient is high risk, then and I don't want them to be on blood thinners every day, then we're probably not going to do a stent. Probably just going to do the angioplasty. Yes.
On the angioplasty, it opens it up, and then how many years does that last, or how many?
Depends on the diet and exercise and medication compliance. Yes.
After they get like a stent or an angioplasty, is like their signs and symptoms of coronary artery disease gone, or?
It should be. It
It's
should
like
be.
a shortness of breath and long.
Right, because we've opened it back up.
But it's not like a cure, it's just a treatment.
No, it's a Band-Aid.
Okay.
Yeah. This is why you don't want to develop in the first place. And then ultimately what you're trying to do is not for them to not have an MI, because that causes tissue death. Yes?
So is the angioplasty the balloon and then they remove it?
Yep. Yep, it just goes in, they blow it up, and then they take it back out.
Doesn't seem like I would hold or stay open.
It's definitely not as good as the stent, but there's just so many risks with the stent because of the blood thinners. So it just depends. And it depends on the degree of the blockage. Okay? So we go in there, we go into the cath lab for one blockage, but we find some other ones too. Okay? There's usually never one. So this one over here is 90% blocked. I'm gonna put a stent in it. But this one over here is 50. I'm just gonna avoid it. Does that make sense? So it depends on that too. There's never usually just one. Good questions. Okay, so they've gone to the cath lab and gotten an intervention. So possible complications. We just talked about some of those, but these are things that I and you as a nurse need to know. So artery dissection. You have a coronary artery that it's already got plaque in it. Plaque is crunchy, by the way. It is not soft and pliable. It is crunchy. And we've just shoved it in this artery wall. Well, that balloon with crunchy plaque, it can actually cause a dissection in that coronary artery. That's real bad. Real bad. So you need to assess for that. And the way you would see that is you're going to monitor vital signs, you're going to monitor their EKG. And if it shows, then it can lead to tamponade, and we'll talk about that in a second. Cardiac tamponade That is when blood fills the sac surrounding the heart. So if I have a coronary dissection, or if they perforated through the coronary artery with that wire, which happens, then blood can fill that coronary sac, causing a tamponade. So how would I know as a nurse? I'm gonna monitor vital signs, I'm gonna monitor heart tones, because we have Beck's triad for tamponade. We have low blood pressure, muffled heart tone, and jugular vein distension. And you just need to know that if we identify that, there isn't a thing us as a nurse can do about it. But we need to assess for it and communicate now, right now. Hematoma near the insertion site, so we talked about that a little bit. So what do I need to do? I need to continuously, periodically be monitoring this site. And then if it's a femoral access, I need to monitor the pulse distal from that site, right? So if they went into the right femoral, I need to really pay attention to those pulses in my right foot. Especially because when you're holding pressure, sometimes you hold pressure too good and their foot turns purple. And you're like, oh, let me back off a second. External bleeding at the insertion site. So hematoma is like a big ball of blood that happens under the surface. And then external bleeding is exactly what it sounds like, it just bleeds out. Sometimes the sheets have metal surrounding them, bigger sheets have metal. And you can hold pressure all you want to, you are never gonna push that metal down, right? So I had a patient who the top came off the sheet, like it popped off. So blood is literally just like hose pouring on the ground, like everywhere. And so everyone's like laying on this guy's, femoral artery, like literally everyone, 2 men, full pressure, it's just pouring out. I was like, you're gonna have to take the sheath out. And they're like, we can't. And I was like, well, he's gonna die. And dude was like, I could see his life like draining from him, from a sheet. I was like, this guy's not gonna die because of this freaking sheet. So we ripped it out, held pressure, had to get him some blood ASAP. So you wanna monitor that side and monitor all your lines. Retroperitoneal bleed. This is really, really a big one. So when they have femoral access, they're going through the femoral artery. If that catheter, if they poke a hole through the coronary artery, or not the coronary, the femoral artery, or in the aorta part of your abdomen, then that's going to leak blood in your abdomen. You can hide a lot of blood in your abdomen before you know it. Okay, that's another benefit to radial access. You can't bleed out there very, very long without us noticing it. But they'll have back pain that is new. That's the key. So remember how I was telling you femoral access, they have to lay flat. A lot of people that are older have chronic back pain. So whenever you are assessing for this, I'm obviously monitoring vital signs for any sort of hemorrhage, tachycardia, low blood pressure. But I need to assess them for onset of new back pain. So they're like, my back hurts, and I'm like, do you take anything for it? Yes. If they say they have back pain and it's new, I need to look into that further. Okay. Acute kidney injury, I'm going to monitor output and creatinine levels, and then I'm always going to monitor for allergic reaction. All right, y'all take your break. This is one of the complications, and I just kind of like to go further with it, just because your arteries here, right? So when they put the wire through it, sometimes they poke a hole through it. Right? They're doing the best they can, and if plaque is in the way or blood clots in the way, sometimes they poke a hole through the coronary artery. They may not even know that they did it. But then we've got them in recovery. And we're doing our assessment, and we notice that they have low blood pressure, or widened pulse pressure, but low blood pressure, muffled heart tones, and then they start to develop JVD. JVD is kind of a late sign, so hopefully you're just identifying the muffled heart tones first. Regardless, they're all bad. So this is a medical emergency. Again, there is no, please hear me when I tell you this, there is no lab, there is no medication that I can do to identify this. People want to be like, oh, I can draw an H&H. Okay, your cardiac, the sac that surrounds your heart cannot hold that much blood. Like 15 milliliters. 30 milliliters is an ounce. So it can't even hold, it doesn't stretch that much. So drawing an H&H is not going to identify cardiac tamponade, okay? There's nothing you can do about it. You need to urgently call the physician. The only one I had of this, it wasn't mine, but I was float nurse that day. It's very common after they have a heart cath with a stent to have some pain. And I know you're like, well, how do I know if it's good or bad? So think about it this way. Have you ever sat on your foot and then you take it back out and it starts tingling and it kind of hurts? That's reperfusion. That's blood getting back to the area that has lost it because I've sat on it. That's reperfusion. So sometimes they have chest pain, but it's reperfusion pain. So there's been an area that's been deprived of oxygen. We've opened it back up, the blood flow and oxygen, and then that blood flow is going to that area that has been compromised, and it can hurt. Okay, it's exactly the same concept. So you are just assessing them. You are, they can have a little bit of pain. It should not be constant, and it should not be progressing. It should not be getting worse. So you're assessing for that, and then you should not have EKG changes. Otherwise, it can be normal perfusion pain. So if they're having tamponade, they are going to have progressive worsening chest pain, accompanied by muffled heart tones and these assessment findings, right? So we had this elderly gentleman who had gone to the cath lab and he had gotten a stent, and he was okay. He was back in his room, getting recovered, and he started complaining of chest pain. Well, it's pretty common. So the nurse gives him something. It doesn't help. I don't know what she gave him. Doesn't help. And he's like, this is really hurting. This is really bad. Nurse calls the doctor. Hey, he's having chest pain. He was like, just keep monitoring. Keep monitoring. He's fine. 10 minutes later, she's like, listen, you're going to have to come check him out. Like, he is hurting really bad. And he was like, listen, he's going to be okay. You just keep monitoring him. This whole time, this poor man was having tamponade. So finally, this nurse was doing everything she was supposed to do. She was calling, telling him the assessment findings. So it is now 5:30. Everyone, ultrasound techs, all of that go home at 5. Doctor comes up there and assesses that this man is indeed having tamponade. And he will not, what's the treatment for tamponade? Cardiophoresis, right? It's the only thing, we can't do that. So that's why we need to call. So they put a needle through, they go under the xiphoid, they put a needle and they draw the blood out. Well, typically this is done under an echo. So you know exactly what you're doing, right? Well, this is an urgent situation. And so this doctor would not perform this procedure until echo got up there. And I was like, dude's about to die, just do it. Well, he did die. And it was the most heartbreaking, that little old woman just laying on her husband. Oh, it was terrible. I'm choking up just now. So, our assessments matter. And you have to speak up for your patients, you have to advocate for your patient, and you have to do what that nurse did. You have to get on the doctor's nerves. Call them. It does not matter, call them. Okay, any questions on interventional management? Okay, so we already talked about medical management, which is medication. Interventional management, which is what they're going to do in the cath lab, those are interventions. That is not surgery. When they go to the cath lab, it is not surgery. Okay? But now we're talking about surgery. So surgical management. Coronary artery bypass grafting, that's a CABG. So this is a surgical procedure where we can restore blood flow to the coronary arteries into the heart by bypassing the obstruction. Okay? This does nothing with the blockage. This is not a stent or a balloon. We literally just bypass it, or we don't, but they bypass it with another vessel. So, yeah, it does not alter the blockage. It is performed under general anesthesia, obviously. And this client is also on pump. They're on the cardiopulmonary bypass pump. So they're basically on like a heart-lung machine type thing, because their lungs have to be collapsed and they have to stop blood flow to the heart. So this machine is what circulates this. The person that monitors that machine is called a perfusionist. It's its own job, and we are in desperate need of more perfusionists. So, if this don't work out for you, it pays very, very, very well. That makes sense, right? Okay. And then the arteries that they take. So there's an internal mammary artery. There's a left internal mammary artery that they'll take down, and they'll use that as a bypass. And then they also use veins. So we know this is kind of where it kind of gets confusing. So our coronary arteries are arteries, right? But they'll take saphenous veins from your leg and put a bypass. Okay? So they'll kind of turn it inside out, and they'll tie off all the little branches of the vein, and they'll use it. So, obviously this surgery requires very intensive monitoring. These patients are sick when they come out of surgery. When we say sick, it's normal. It's just that they are very compromised hemodynamically. They need a ton of support and a ton of assessment and paying attention to. Also know that when they get this saphenous vein out, used to back in the day, they would cut all the way from the ankle all the way up, like a full incision, and take it out. Well, now they really do endoscopic vascular heart, so they'll make a little cut, and they have a tube that is like a blade on the end, and they just run it up the leg to get that vein out. I asked a physician, because there was a physician I worked with that always still cut. I mean, full incision, you know, and I was like, why do you do that? Like, no one else does that. And it's such a pain in the butt to care for because of all the complications that can arise and all that. And he said, when you do it endoscopically, it decreases the viability of the vein, the integrity of the vein by like 40%. He's like, and I want my patients to have the best they can have. And I was like, oh, okay. But no one else does that, so. All right, so here are just some pictures. So here is the machine, cardiopulmonary bypass machine. Here's the perfusionist. Here is a vein that they have gotten all ready to do some bypass. You can see here some bypasses here. So you can see where the vein bypass, so you can see where it completely bypasses the coronary artery. Goes straight from the aorta past that blockage. Okay? And then here is the open vein harvest, and here's the endoscopic. Something that you need to know is how does our body exchange fluids? Through our vascular system. So we now have a patient that has their saphenous vein, which is a huge vein in your leg, has now been taken out. So I need to understand and educate my client that they're going to have more edema in that leg for several months while the body tries to figure out how to distribute those fluids. Okay? Definitely whatever leg they take it out of is going to be more swollen. Bypass surgery lasts about 10 years, give or take, on lifestyle. So it is not uncommon for patients to have multiple bypass surgeries. So if they had one years ago and they took the vein out of the left leg, they'll take the vein out of the right leg. And then if they've used all that, they can take it out of the arm. You take it out of that, and you take it out of the other arm. And then they can use mesenteric. I've had patients that have had it done, this is their 5th time.
Must be like this high risk surgery, like in the.
Oh, it's extremely high risk. It's very high risk surgery. So we saw the sternum open, and then they crank it up. Has anyone ever watched one? It is awesome. It is so cool. Also, since they take down that left internal mammary, they crank this left side up more. Well, I didn't know that until surgery. Patients always complain of more back pain, like right here on the left side. I'm like, yeah, they like pulled your rib cage over on that side. Some people don't want to know that. Some people don't. But then it helped me understand, like, that's why you're more sore on that left side. So, cut that open, and then when they put it back, they use big wires or metal cables. And we'll talk about, yeah. So it's a big surgery, right? Big, big, big deal. It's my favorite patient to take care of, those cabbage. Alright, so post-operative cabbage nursing assessment. So obviously, we're gonna monitor for hemorrhage. They have had massive, let's see, they have to take the blood out of the heart. So they like put hose, like cut and put these big hoses in the aorta and different parts of the heart. So you're monitoring for that type of hemorrhage, you're monitoring for hemorrhage in the sternum, they've got drains everywhere, you're monitoring for hemorrhage. And how I know if someone's hemorrhaging if I can't see it? Vital signs, right? Heart rate's gonna be up, blood pressure's gonna be, yeah. Yes.
So like that vein being removed, it shouldn't affect any of the circulation in those veins?
No, it's gonna be more swollen for a while, yeah, cause it's a vein, not an artery, so. Alright, so monitor for decreased cardiac output. Their heart's been under a tremendous amount of stress, and typically when they're done, they have to shock the heart back to life, so then you have that in itself. Renal perfusion. The reason we do this is because when we have decreased cardiac output, that kind of goes along with it. So I'm going to monitor my eyes and nose. Signs of infection. This is really important. However, right after surgery, just about every single time, their white blood cell count is going to be through the roof. Does that mean infection? No. Right after surgery, that does not mean infection. They can even have fever with it. When you have a massive inflammatory response, sometimes you can have fever. This is just because of a massive inflammatory response from surgery, okay? But as they go through the recovery, I'm always going to monitor them for infection. Pulmonary complications. So anytime I have decreased cardiac output, blood is not pumping out very well, so then it's going to back up. So then that leads to pulmonary complications, pulmonary congestion, pulmonary edema. And then also, if I've just had surgery and my sternum has been cut open, am I going to want to take deep breaths? Y'all know they do not. I'm sure it hurts so bad. So pneumonia is very, very common. Your incentive spirometry, very important education. I always tell them 10 breaths an hour. So if they're watching TV, I say every time a commercial comes on, do 2 or 3 breaths. It's enough. Also, if they start running a low grade temp, day 2, day 3, work on that incentive. It'll usually get rid of that fever. Or if they don't want to use the incentive, you can, and this is for everyone, tell them to take in a full breath as deep as they can and then blow out through pursed lips. So smell the candle or smell the roses, blow out the birthday candle. Does the same thing. Exact same thing. And then sternal precautions. So we cut open the sternum. Kind of important. They cannot lift, push, or pull anything with their arms because you worry about that coming apart. And I want you tonight to get in and out of your bed without using your arms. It's really hard. And where do we put them right after surgery? In their bed, right? So that is really one of the biggest teaching things. You have to teach them how to do everything without, and it is hard. So that is a huge point of our education, not only for the patient, but their families too. Takes a good 6 weeks plus for that sternum to start healing really well. And if it comes apart, even under the skin, they are at risk for infection like nobody's business. We did have a patient one time that got up way earlier. They were not supposed to get up without asking because they were on the morphine. And they tripped and fell and hit their sternum on the end of their bed. Like, bet you should have pushed your call out. No, that was bad. It was real bad. Real bad. All right, ABCs. Always remember your ABCs. That's your priority and safety. And then look, listen, and feel. Remember how important our assessments are. I'm not going to read this to you, but this goes into detail and like what our assessments findings can mean. So spend some time with that on your own. It is important. All right, and then we're going to wrap up coronary artery disease in a nice little nutshell. Okay. So coronary artery is blocked by disease, which is plaque. That's coronary artery disease. This decreases blood flow, therefore oxygen to the heart muscle past that blockage. This is why oxygen is usually your first treatment. Like on test questions and stuff, they're like, what do you do first? Put the nasal cannula on. So even if their stats are fine, you are trying to increase, remember on the ABGs how the O2 can get above 100? Like you are wanting to get so much oxygen in the body. This is a situation why it's okay. That's why oxygen is first line treatment. So this can lead, coronary artery disease can lead to angina or even an MI if that blockage ruptures and completely occludes. And then we can either give medications, interventions, or surgery for this disease, depending on how bad it is, depending on the patient, their status. Questions? Okay. All right, heart failure. My goal is to get to like slide 50 and then be down, okay? All right, so heart failure. So heart failure occurs when the heart muscle is unable to pump effectively. So essentially it's decreased cardiac output. So this can be caused by all kinds of things. All kinds of different myocardial abnormalities. It can be caused by dysrhythmias. Anything that it decreases the cardiac output of the heart for a duration of time. So it is a chronic problem, right? It's usually a chronic problem. And our whole goal with treatment and everything is just to reduce exacerbations of it. So if they have heart failure, they're living with this disease. Does everyone that has heart failure, they live in the hospital? No. So we are talking about acute episodes, which require treatment, or we're talking about chronic compliance and maintenance. Okay? Does that make sense? So left-sided, it refers to dysfunction of the left ventricle. Right-sided, the right side of the heart. Makes sense. All right, who's at risk for heart failure? Just about everyone. Okay, so those who have coronary artery disease, so remember me talking about if they have coronary artery disease or an MI, how that muscle past that blockage has been compromised. So even if someone who's 40 years old comes, they've never had any kind of health problems, but they have a massive MI, after that heart attack, if they wait, we don't get blood flow back to that area soon, that muscle is going, we're going to get blood flow back, but is it ever going to be the same? No. So I'm going to have decreased performance of that ventricle muscle, and now they're probably going to have heart failure the rest of their life. So coronary artery disease, hypertension is absolute heck on your heart. The same things, the diabetes, obesity, and smoking. High sodium diet, any sort of valvular disease, COPD, and pulmonary fibrosis. All of these things can cause heart failure. So what does this look like? I will tell you on this slide it differentiates left and right, but it really doesn't make any livings, okay? Because most of the time patients are going to come in with fluid overload in their lungs and edema in their legs. It's very rare that a physician's like, left-sided heart failure. They just are like heart failure, okay? So left-sided lungs, right-sided, you're going to have your dependent edema, so in your legs. That's about all I'm going to spend on that part. But usually they have both. And anytime I have fluid in my lungs, I know what that leads to, right? I know the assessment findings, and if I have low perfusion, low oxygenation, what's that going to make me feel like? Like crap. Weak, lethargic, altered mental status, and I have a low pulse, all those things. Okay, stages of heart failure. So what you need to gather from this is the higher the number, or the more progressed in the alphabet, the worse it is. Okay. So around Central Arkansas, most cardiologists are going to use the 2, 3, 4, or 1, 2, 3, and 4 scale. So what you need to gather from that is if my patient has stage 4 heart failure, they're really sick. Okay? So if I have a patient in the hospital and I read their note and they have a stage 4 heart failure, and I've got 4 IV antibiotics I have to give them and they're all in big volume bags, I need to be paying attention a little bit more closely to their respiratory status. Does that make sense? So I know that they are progressed in their disease and they can't handle a whole lot of anything. Okay? Okay, so how do we know someone has heart failure? Or how do we know that they're in a worsening state? So labs and diagnostic tests. So your BNP is going to let us know how progressed they are or if they're having an exacerbation. So normal range is less than 100. That's where it should be, because that means no heart failure. So for normalcy, less than 100. And you can see here, 100 to 300 suggests heart failure, 300 and up mild heart failure, 600 and up moderate, and over 900 severe. It's not uncommon to see really, really high levels when people come into the hospital. So this can not only let us know what stage of heart failure they're in or what status they're in, but it can also help us to guide treatment. Because if they come in and the physician orders furosemide drip, blah, blah, in order for me to know how well it's doing, I'm going to monitor eyes and nose, and then I'm going to redraw a BNP the next morning. I should see the BNP go higher or lower? Lower. So then that lets me know that the treatment plan is working. Does that make sense? So then it can guide clinical decisions, and it can track progress in that way. Echocardiogram, this is what we talked about earlier. Non-invasive, it's just an ultrasound of the heart. This can give us information about that left ventricular function. Talked about the EF, normal is 55 to 70. And then heart failure is classified based on the ejection fraction. So we have heart failure with reduced ejection fraction, and then we have heart failure with preserved ejection fraction. So if they have heart failure but their EF is within 55 to 70, then they have heart failure with preserved ejection fraction, right? Or if they have heart failure with an EF of 35, then they have heart failure with reduced ejection fraction. That's just how they note it. And then ejection fraction of 45% or less is pretty significant weaker contraction of the heart. So you can see how that's a pretty narrow range. Normal is 55 to 75, but 45 is kind of bad. So that's not a whole lot outside of that. And then a TEE is just a transesophageal echo. So it's exactly what it sounds like. They go down the esophagus and they just have a closer picture of that heart versus going through the chest, especially with someone heavier chested or things like that. It's a much closer picture. However, can I just put a tube down someone's esophagus? Do you like that very much? No. So what do you think that requires? Sedation. NPI after midnight, sedation, all those things. So then that becomes an invasive procedure, whereas an echo is non-invasive. Okay, and then chest x-ray. This is like really, really helpful, especially when someone comes in with an acute exacerbation of their heart failure. So it's an x-ray of the chest, because that's what a chest x-ray is. And it can reveal how big the heart is, pulmonary edema, pulmonary effusions. I know no one in here is a radiologist, however, get used to looking at your chest x-rays. Just check them out every day. You will start to pick up on things, and then you can read your notes, and you will be able to start identifying so much, especially in heart patients. So you can see how this first picture, that is a normal chest x-ray, okay? You can see how small that heart is. And then this one is someone who has cardiomegaly from heart failure. And that is not uncommon. I mean, these hearts are stretched out, they're huge. What else do we notice on that x-ray? Uh-huh. Yep. We have heart failure with a really weak ejection fraction, so weak that they need a pacemaker with a defibrillator. And then this is the same, but they have all of this pulmonary edema. So you can see how that looks different in the second one. Isn't that cool? All right, management of heart failure. So again, we have medications, we have interventions, and we have surgery that we're talking about. So medication management, of course, we're going to try to manipulate that cardiac output. We're going to try to get as much out of it as we can. So we're controlling the fluid volume within them, and then we're trying to treat the underlying cause. So whatever whatever their cause is from going into heart failure, that's gonna be where your directed treatment goes. Does that make sense? So there were a lot of things on that list that can cause heart failure. So if they have heart failure due to a valvular issue, I can give them medications to treat their symptoms, but they're gonna have to address this valvular issue. Does that make sense? So we're gonna have to address whatever is causing it. So medications to support them, we've got preload reduction agents. Preload is what? Volume. So that's diuretic. Afterload reducing agents. Afterload is what? Pressure. Blood pressure medicine. Positive inotropes, so we're gonna increase that contractility. We're gonna make it stronger. And then beta blockers. Beta blockers decrease the workload of the heart. They are really, really good for a heart that is having to overwork. Everyone after a cabbage, we put them on a beta blocker because that heart rate wants to go up, up, up. And we want to keep it 60. Let it chill. Alright, so diuretics, we use these to decrease preload, which is volume. We've already talked about some of these. So you have furosemide and bumetanide, those are both loop diuretics. We know you give it no faster than 20 milligrams a minute. And they're going to deplete what electrolyte? Potassium. We're going to watch that. And then we have your HCTZ, hydrochlorothiazide, and then you have your potassium sparing spironolactone. However, you need to understand that these two in the middle, the thiazide and the potassium sparing, we are not using those in acute situations. We're using those for chronic management. Acute situations are going to be IV, and it's going to be furosemide and bumetanide. All right, blood pressure medicines. You've got your ACEs, you've got your ARBs, you've got your calcium channel blockers, and you've got some vasodilators. So with all of these, what's my role? I'm going to monitor for safe administration. So before, I'm going to check their blood pressure, and then just, and if it's low, I'm not going to give it. But if it is high, I'm going to give it. And then how do I know it's effective? I'm going to evaluate what their blood pressure is afterwards. Education-wise, whenever I'm sending someone home with an ACE inhibitor, I need to educate them on things that can happen. So the angioedema, you know what that is?
Yes.
Yeah, it's like massive tissue swelling. You need to educate on this because it doesn't matter how long they've taken an ACE inhibitor, they can have it out of the blue, and it is impressive. Google you some pictures of it. Oh my gosh, I'll never forget. First time I had, you get it all the time in the ED. I had no idea when I worked in the ED. This woman came in and she was holding a rag on her lip. She had called 911, obviously, like mouth swelling is bad. She had a rag over her lip, and I was like, let me see. She was like, I was like, let me see, I gotta know. She took it off. It looked fake. I mean, they were huge. And I was like, oh, that's cute. She's like, shut up. She's just drooling everywhere. The doctor's like, would you quit? Get a kid at the bedside. And I was like, oh, okay. I was like, she's talking. But I mean, it is impressive, and it can affect lips, tongue. So obviously, that is an airway issue. So we give them all sorts of things, and then keep a trach kit at the bedside in case we need to trach them. Because you're not going to ET tube them. So that's a huge education point. And then the dry ACE cough, that's something with chronic use. And I guess they can call it a rash. What can't? Okay. Positive inotropes. We know that these medications increase contractility. Some of these probably sound familiar, hopefully. So DID is one that's given it, like it's a pill, given at home. You can give it IV push, but IV push use is going to be more for AFib with RVR versus management. Dobutamine, Norino, and dopamine are all medications that we can give to increase the contractility of the heart, but they require continuous monitoring because they are continuous drips. So that means they're going to be where in the hospital? ICU. Now there are places at Big Baptist like 9A, 9B, where they can be on dobutamine and milrinone. Because that's very common in the patients they have. So, And then beta blockers, they end in LOL, and they decrease heart rate, myocardial workload. They let the heart rest a little bit. So we need to monitor and make sure that their heart rate and blood pressure doesn't get too low. And then self-management of heart failure. This is key to everything. This is where our education is imperative. Because this is a chronic problem, right? And so we're trying to decrease hospital admissions. Y'all know that if someone's admitted within 30 days of discharge, the hospital has to pay for it? You know that? And I know you like to get paid, I like to get paid. The issue with that, in my eyes, is that we cannot go home with people so we can educate till we're blue in the face. But most patients live in rural areas, and what's on every corner of rural area is Dollar General. So they're getting their groceries and food in there, and there's nothing healthy there. So, but that's a real problem. That's a real problem. So then you kind of talk about Meals on Wheels, trying to get some sort of healthier diet things for your patients, and that's part of our job. Self-management's a critical component because it is all about compliance. It is all about compliance. They have to, this is a chronic health problem, it's not going away. And so we need them to take their medications. Poor communication and lack of continuity can be barriers. Just because someone has had heart failure for 15 years does not mean they have been educated appropriately. So you don't talk down to people, but you don't talk to them like you should know. You have to assess what they know. Okay? We have to also assess like a 5th grade level. Honestly, I think that's probably lower now. Clients are responsible for monitoring their own symptoms, taking their medications, and weighing themselves. So we tell them 2 pounds in a day, 2.2 pounds in a day, and 5 pounds in a week. If they have that, they need to call. They need to call their doctor because they're retaining too much fluid. Good thing is there's a lot of heart failure clinics now, so they can call their heart doctor and get into that instead of going back to the hospital, depending on what resources are available. And then, of course, restricting diet. So I was talking about Dollar General, but legit, that is the thing. So, you know, Viennese are basically salt blocks. So those kind of things. I love them. All right. So that was medical management. Compliance is a huge, huge part. Medical management compliance. Interventional, as heart failure progresses, more invasive treatments are needed. Okay, so as their heart gets weaker, as their ejection fraction gets lower, they are more prone to life-threatening ventricular dysrhythmias. Okay, because their heart is weak. So when your heart's weak and the pump is weak, the electrophysiology parts are also weak of your heart, the electricity. So then they are very, very prone to go into ventricular dysrhythmias, which are what? Lethal. So they can have an internal cardiac defibrillator implanted. So, but it can look just like a pacemaker. So when you're assessing your patient, you need to ask them, like, is that just a pacemaker? Is that a defibrillator? And if they have a defibrillator, you automatically know they have chronic heart failure and they have a low EF. I automatically know that. I know that. Right? So then that tells me so much information. I need to monitor how much fluids I'm giving them, like all kinds of stuff. Just from when they walk into the ER, I can ask them, is that a defibrillator or a pacemaker? And I already have an algorithm in my head of information. Yes?
So I have a question. So when we were doing community health, I had a patient who wanted an IUD inserted and she had a defibrillator. And they were like, oh my, why didn't she tell us before? Do you know why?
I have no idea.
Okay.
I try to stay out of women's health. I don't know.
Okay.
No IUDs around here? Okay. I don't know. I don't know. So, yes.
So if a patient like is in the early stages of heart failure and they're complying with their meds and lifestyle changes and everything, does the heart continue to fail or does it stay in that stage?
Depending on what the cause is, it can definitely improve. But ones that are just living with this chronic problem, you know, whatever, then they're going to have to do all these things to keep it from progressing. But if someone has the ejection fraction of 35% or less, then they are a candidate for an internal cardiac defibrillator. 35% or less, yes.
My dad had heart failure and got a pacemaker put in, defibrillator. And they gave him a chart, and it looked like it was a very professional looking chart, but it showed your quality of life over time, and it was a gradual decrease. It was like, this is what's gonna happen to you with the pacemaker, but then it had like, the one without the pacemaker was, you're gonna have a heart attack and die here, you're gonna have a heart attack and die here, you're gonna have a heart attack and die here. But it was kind of a crappy looking
Yeah.
decrease.
Yes. Yeah. So for this, the defibrillator is just going to shock you back if you have a lethal arrhythmia. It's not going to increase your ejection fraction. Now they can put in like a biventricular ICD, and it can kind of help the heart pump a little bit better, but it's not a long-term solution. So other interventions could be continuous IV inotrope therapy. So this is when they come in the hospital and they get put on dobutamine or milrinone, and it helps a lot. It's just that it's not. I mean, you're gonna have to stop it at some point, right? So it can be kind of challenging. And then surgical management. So a ventricular assist device or an LVAD. Mechanical circulatory support device. So this is a left ventricle. It's a mechanical left ventricle, okay? Are y'all in the generation that watch Grey's Anatomy? Yeah. Don't cut the wires. So this machine is so cool because it pulls the blood from the left ventricle and pumps it directly into the aorta. So it like bypasses the whole heart. It's really cool. But you need to know that they're not going to have like a pulse with this. Real freaky. And then you have to check their blood pressure by ultrasound. So, kind of different. But don't ever cut the wire just to get to the top of the transplant.
He still died.
I know.
Yeah, that was hard.
It was hard.
Alright, so LVAD and then ECMO. So ECMO stands for extracorporeal membrane oxygenation. Y'all heard of ECMO? Yeah. People are sick when they get put on ECMO. So it's kind of like that cardiopulmonary bypass machine I showed you during surgery. It's very similar to that. So they take the blood from your body, oxygenate it, and then they put it back into the body. This is not for every client. This is for clients that are having severe issues with oxygenation systemically, and it is not a long-term solution. It is very short-term to hopefully address the main problem. So these are specially trained nurses. They actually have a unit now at Baptist, ECMO unit. This freaks me the heck out. Like, no, do not do that. I mean, they have these catheters in big areas, and if it comes out, like they're dead in 2 seconds because all their blood is on the ground. So that just freaks me out. And during clinical, we were in CCU, and this guy comes in and he's just walking. And I was like, oh, what's he pushing? And they're like, oh, he's pushing his ECMO. What? Why is he awake, alert? But it actually, I mean, it makes sense. It's just that makes me nervous, right? So now if they can get them up and moving, I guess it's better. I was like, y'all clear the way. Don't even look at it. And then of course we have heart transplant. So this of course replaces the heart. This is an option when everything else has failed, but it's not like you can just be put on the list by any means. There are a lot of people walking around with LVAD, way more than you think. Start paying attention. So see this little vest, little battery pack? Start paying attention. Restaurants, Walmart. You'll see actually several. Yeah? That's crazy. Okay. And then we're going to wrap up heart failure in a nutshell. So heart failure occurs when the heart's weak from something. It can be all those things, right? All kinds of things. But the heart cannot keep up with the demands of decreased cardiac output. So we just have profound decreased cardiac output. So this causes pulmonary and systemic congestion. So we have pulmonary edema, And then, and then we have dependent edema. So we have fluid in the lungs, we have fluid in the legs. Treatment is focused on treating the primary problem. So we can give them medications to support their signs and symptoms, but we have to address the main cause. And then we're trying to obviously keep that EF from getting lower. We're trying to keep them from having exacerbations. That's the whole goal. And then the lower the ejection fraction, the worsening the stage of heart failure. That's going to lead to more acute problems, more exacerbations, and more aggressive treatment. Okay? That's when we start having to get all kinds of devices and more things. And then as for us, our role, what's my role in this? Why do I care? I need to do eyes and nose. I need to daily weigh them. And then I have to teach. Teach. Even if you get the same patient 5 weeks in a row. Mr. So-and-so, we're here again. I'm going to teach. Then I'm going to document that I taught, right? Okay.